All right. PK, can you hear us?
How are you?
Okay, great.
Okay.
Andre just showed us a very nice case using some covered stents. So
yeah, we
what do you have?
We had the pleasure of watching it from up here. So we have an interesting case, very different than what was presented, and I think it brings up certain challenges and questions that we all face while dealing with these kind of cases. So Sandeep?
Sure. Morning, everyone. So, following up on with in another case of in-stent restenosis, this is an 83-year-old guy, multiple risk factors, hypertensive, diabetic, coronary artery disease, has heart failure, has atrial fibrillation for the last 7 years, on Eliquis. He's an ex-smoker with a known PVD. And he had right SFA angioplasty. We don't have the full details, but he reports that it was at least 3 years ago. And then, once we had further history, which is not up on the slide, but he told us that he had another balloon done on the right leg about a year and a half ago, and we got details that was a drug-coated balloon which was done at the outside hospital. So he presented to us with worsening claudication over a year, and given his age and multiple risk factors, and the ABIs were 0.77, we actually wanted to try exercise therapy first, and we did a smoking cessation. At that time, he was smoking, and he's not a candidate for Pleatal because of his heart failure. We watched him closely. We followed him every 6 to 8 weeks in the clinic. Minimal response. He actually worsened from 3 to 4 blocks down to 2 blocks. Next slide, please. We did a repeat ABI before we kind of committed to another procedure because, recurrent restenosis, we don't have clear data. And his ABIs was worse. On the right, he was down to 0.66. We did a duplex also to define better, and he had a peak velocity of 308 with a ratio of 3.2 at mid-SFA with multiple areas of ISR. And below knee, there was at least a 1.5 vessel runoff. Labs pretty unremarkable. Creat of 1.13 today, it's 1.4. We'll be careful with the dye. Medication-wise, he's aspirin, atorvastatin, insulin. He's on Eliquis 2.5, and we could not give him Pleatal, which initially we thought we might.
So Mike, I just wanted to go over what we've done angiographically, and you can see here that what we did was we went ahead and did a initial iliac-affine, a runoff to see whether there was any stent fracture or not, just a plain cine.
So we're not seeing those pictures yet, PK.
Okay.
Oh, there we go.
All right. So
Thanks.
you can see you see that you have it looks like one area 2 layers of stents. The other area is probably single layer of stent. But clearly this is a guy, we got the report, he had a DCB, it was an impact DCB that was performed for in-stent restenosis of a diffuse segment. So we went ahead, and then after that we said, okay, let's take a runoff. So when we did our runoff, pardon me, I'm pressing the wrong button here. So we did a runoff here. You can see here he has diffuse restenosis of the entire stent, proximal mid, more severe, with basically looks like 2 vessel runoff with the posterior tibial occluding in the foot. So we just did some DSAs below the knee because of dye issues, and you can see that the DSA did confirm that he has 2 vessel, robust, with a severely diseased and later occluding posterior tibial vessel with runoff into the foot. Obviously moves on that one. And then you can see in the foot, you'll see the dorsalis pedis and the perineal artery being the more robust out of the vessels, and the posterior tibial is not visualized. So at this stage, we decided to do an IVUS offline because, my question to the panel, I know we haven't heard Nick's talk or Chris's talk yet, but, the issue here is that, how do you deal with this? So here's a gentleman who's had, bare metal stent therapy, we're assuming, but I think looking at the timeline and where it was done, I don't think they have Zilver in that lab at that time. So he definitely had bare metal stent therapy, followed by a drug-coated therapy for restenosis. Now he presents with intermittent claudication of failing medical therapy with actually multiple severe restenotic areas. So we did an intravascular ultrasound offline. Can you show up the intravascular ultrasound, guys? Again, Mike, we're using a lot of IVUS to really kind of define what we're doing. And you can see here, I'm just going to show you, there was no evidence of stent fracture, and this is pretty much what we saw in the diffuse areas. I'm not going to play the whole IVUS, make everybody dizzy. And you can see here that he had quite severe restenosis throughout and tighter in certain areas, but it wasn't thrombotic. We were expecting to see thrombus. We were trying to figure out why he kept restenosing throughout the stent and trying to figure out a mechanism of failure. So at this stage, we're kind of at a loss. How do we treat this guy? Do we do laser? Do we do a covered stent? Or do we do a jet stream atherectomy followed by another therapy? Whether it's a scaffolding or not remains to be seen. So just for the sake of time, while you guys talk, we felt that we wanted to debulk the lesion because probably just putting drug in may not be enough in this particular resistant restenosis, and so we decided to do jet stream. And I'm going to go ahead and start doing it. And there is data on jet stream. I know that Dr. Shamas, who's kind enough to be on the panel, is going to start a study and has published extensively on this particular modality. So I'm just going to go ahead and start and just wait for any comments, Mike.
Thanks, PK. So Nick, maybe you can comment.
Yeah.
We haven't heard your talk yet,
Well,
but
PK,
perhaps you can give us a preface of it.
Yeah, I think this is an excellent strategy we use in our lab very frequently for ISR. One of the things that you need to look for is stent fracture, and class 3 and class 4 stent fractures really is a contraindication in that case. But in this case, it's perfect. You don't see any fractures. We tend to use filters in all the ISR. That's typically our practice. Even with the JetStream ISR trial, we've seen almost 9% embolization. 2 of them were without a filter, and one had a spider filter in it. But the point is, it's a very effective strategy. Debulking is essential. These are watery sponge type of tissue morphologically, and ballooning them only is not going to be sufficient.
So Nick, we have used a EmboShield from Abbott, which is off-label at this stage. We felt that the larger size filter would allow us to capture more debris. We made one run, blades down, offline, again, for the sake of time. And what we're doing is we're just going to go blades up now with a 2434 Jetstream device. And I don't know whether you would agree. Go ahead on. One of the things that I do is go very, very slow with my runs and shorten my duration of runs to reduce the embolic debris that's going to go fill my basket. We've got our bailout strategies for that, like all of us do, but at this stage, I'm just going to run this once and take a picture.
Yeah, PK, absolutely. Slow run are essential, and you have to make sure that your aspiration port continue to aspirate at all times. If you lose your aspiration, more likely than anything else, you're going to be embolizing. So that's really important to keep an eye on that aspiration port at all times.
So would anybody else in the panel, Brian or Chris or you, Dr. Bacharach, would you do anything different? On?
I think that the Impact Global registry would suggest that you can just balloon this alone with DCBs and get a good result. That said, I think he did have a reasonable result, right? If I'm not mistaken, you said this was a few years ago that this was last treated. And regardless of the results of that global registry, I do agree that debulking in most cases is optimal. You're not going to get rid of that tissue simply by angioplasting it, despite the fact that the Impact Global showed some good results with that. So I do tend to debulk them as well. Lasers on label for debulking, that's why I like that. At the same time, I think the excisional atherectomy, although contraindicated, as long as you are careful to avoid the stretch, you get a really phenomenal amount of debulking, and you can very much see that on IVUS. So I tend to use TurboHawk for a lot of these in an off-label fashion.
So PK, this is Chris. I like the strategy. This is our default strategy for cases like this. The only thing I would say is, especially with IVUS, and if there's under-deployed areas of a nitinol stent, I would use the 2.1 to 3.0 in the SFA and use this one more in the common femoral. It's a pretty aggressive debulking. And as you say, you got to make sure there's no stent fractures or no area of under-deployment. And if you get that resistance that you heard, I would go back down to blades down and make a run or two, and maybe even skip the aggressive part in that one little part. And I applaud the use of the protection system you used, because the independent wire there that you can put way downstream in the tibial, you're not going to move the wire, or excuse me, the basket, if you make minor movements in the wire. This is our strategy as a default for most in-stent restenosis.
So Chris, as you can see here, we did exactly what you said. The wire is down in the dorsalis pedis. We actually watched the filter while taking it out, and we actually dropped it to blades down across that resistant area distal. And you saw the scout run to make sure there was no fracture. So at this stage right now, I think we're going to take a picture. We're going to re-IVUS, get the IVUS ready, guys, the DSA, one shot of the filter. And then we're going to hopefully not see a full filter. Go ahead.
I'm going to ask the panelists, comment on your preferred atherectomy device. It's one thing about orbital atherectomy, the other directional atherectomies. Just from a practical standpoint, I would, the directional atherectomy in this case, it's long, time-consuming. I get impatient. It's not. So, I mean, do you have a sense? Do you prioritize? Is it because you like a certain device, or you think you get a better result, or is it what you have in your lab? How do you go through that decision process?
Ready? Give me the.
Ryan, maybe you can comment. You brought up the issue of a directional atherectomy.
Yeah, so for me, I think that with some devices, pathway laser, you can get a great result, but if you don't get a great result on that first couple of passes, you're not going to change that very much with additional work. Whereas with excisional atherectomy, you can continue debulking until you get the result you want. So that's one of the reasons I favor it for large volume of debulking. It is time consuming, certainly, and you can mitigate that amount of time you're spending by using IVUS and focusing on the areas that seem to be most heavily, they require the debulking the most. And this is a good case. You can find areas along this diffuse stenosis where there are some areas that are more of a problem than others, and I would focus on those.
So, the reason we did IVUS here was really more for thrombus. And so what we wanted to do now is to see, live on the IVUS, guys, we want to see how this plaque looks now. Ready? You can see the IVUS. I'm going to just start pulling back. I'm just fixing my wire. You can see that it's more of a fibrocalcific plaque that you're seeing. Our lumen is a lot better. We have made a lumen with the Jetstream device. And as you can see, the stent also is not fractured at any point. That's a very impressive lumen there. And you can see a little bit of compression in that area. And that looks like a double layer there. And as you keep coming back out, we have made a lumen. And we know that Tom Davis showed with IVUS images that Jetstream didn't give as much a bigger lumen as this directional atherectomy device. But I really believe that here, for me, is more about breaking up the fibrotic nature of this plaque, allowing me to expand it, and then allowing me to then give a definitive therapy. And that's what I want to move to next. So we know that this patient has failed DCB. We know this patient has heart failure. So my worry about using a covered stent technology the way Andre did was that the flow is not going to be ideal for covered stent. He is on Eliquis, which is going to help us going forward, again, which is off-label in terms of the use for peripheral arterial disease at this time. So my question is, would you guys do another drug-coated balloon? Would you say, would you do another stent, which I don't think it may not be a wrong thing, another scaffold, but this time use a drug-coated stent, or would you just use covered stent technology and say, I would leave this alone?
PK, when was his last DCB? Was it 3 years ago?
It was a year. It was a year and 2 months ago. Is exactly what it was.
So I would go with DCB here, quite honestly, or Viabon. I wouldn't do another nitinol stent in that long of a region, and that'd be a lot of nitinol stents. You got a pretty good result there. I mean, that looks pretty nice, and you don't know what the other operator did in terms of debulking before the DCB. So I think I would either DCB the entire thing or Viabon, one of those two.
The other thing to consider is there's a difference between a complete occlusion, the downside of using a Viabon in a complete occlusion compared to the downside of using it in a stenosis. And so if you have restenosis that is not occluded, I'm a little less willing to put a covered stent in those areas. If you have a complete occlusion, then you're not losing any collaterals if that Viabon goes down. I think you have less of a downside to a failure of that Viabon. Whereas here, if you're going to line the entire thing with a series of Viabons, it's going to be a fairly long segment, and then you've essentially done an endoluminal bypass.
Is this a 6x150 DCB?
This is a 60120 nanocross, or maybe this is an Abbott. I'm so sorry. This may be an Abbott 60120 balloon. I'm looking at the wrong camera. So therefore, we're going to balloon this just to see how it responds. And my question is, Dr. Zeller has data with the Zilver. The Zilver PTX PMA has shown that in the Japanese study that it works very well on ISR. So my question is, what is you've already burned different bypass options to this area. What do you lose by putting a layer, but this time using a scaffold? rather than a drug-coated balloon? Because that's my question here. Is that something, if you had either a Eluvia stent, which has a polymer that would stay on and elute over a period of time in the future, or in this case, use a drug-coated Zilver PTX to prevent, to have that scaffolding present to prevent the neoendamental hyperplasia? Is that a wrong thing or in the wrong thought?
Well, PK, I don't think it's necessarily wrong. I think that, one of the issues here is you already have a fair amount of metal material in place.
Exactly.
And going back to Chris's comments, you really don't know what the first operator did with regard to the DCB. The adage about trying to leave less behind is better. This may be a situation where, number one, you may be using a optimal or improved balloon technology than what was used by the previous operator. Now that you've debulked this really quite well, as evidenced by your IVUS, you have a better lumen. The idea then would be to use perhaps a drug-coated balloon through this segment and see. You may very well get, it may be an optimal strategy initially with the idea that if it fails, then you can always come back. I mean, I'm not sure that putting more material in would be my preference. But I don't think there's anything wrong with it. No one's going to, and again, the other issue, of course, there's cost to all of this. Cost to covered stents clearly are expensive. DCBs are fairly expensive. Drug-eluting stents are more expensive than standard bare metal stents. So I think that all of that has to be considered, I think, in the algorithm as you go through deciding how you're going to treat this.
So then if you say DCB with the panel, I think the panel says either DCB or covered stent, would you try a different DCB? Because obviously you have the Lutonix DCB, which hasn't been used on this patient, or the Stellarex, and in the future we'll have the Ranger DCB. So my question is, what is that thought process? Or would you say, I've debulked now, I'm going to go with Impact again and give it another shot? Let's do a DSM.
So PK, we're going to let you decide that, because we're going to go to Leipzig, and we want to see the result, and then we'll come back to you. Okay?
All righty, you got it.
All right. Thanks, Chris. Nicely done. We're going to go here to PK, and PK, you're going to show us.
Yeah. Well, you know what, Mike? I tell you, with the enemy of good is always better. And so what we did was we said, okay, you know what? Everything that was said by the panel made a lot of sense, and kind of the same pattern we were thinking about. So we decided to do a DCB. We picked a different DCB, which I thought was logical. Be careful with the other wire. It was logical when they're watching, so don't do anything. So because of that, we did a different DCB, and when we did it, you saw there was a difference in the flow. So we said, oh, brother, what does this mean? So we went down and we took a look at our filter, and as you can see, the filter is full.
Yeah.
So I don't know how something embolizes. Is this drug debris that is embolized? Is this thrombus from a lack of an ACT? Or what is this? So therefore, we're checking an ACT right now. I do not believe it'll be a problem with our ACT because of the fact, and I'm proven right, because of the fact that we're on bivalrudin. Could it be a embolization of drug material? Unlikely. I just think that we went up to really, nominal pressures with a appropriately sized DCB, and we embolized some plaque. So now what I've done is I think this is illustrate what Chris and the panel said, is that you have a tremendous amount of plaque in this grumous material, and so now we've got a filter which is saving us. So at this stage, I'm going down with a multi-purpose catheter because the penumbra device it would have been ideal. However, it doesn't quite fit this area with the sheath that we have, and we have a Cook sheath. The dilator of the Cook sheath is not allowing us to go in. And I think it's important here, you can see the stent, this may be a little bit tricky, and the multi-purpose allows us to steer away from the stent. So you can see here we're taking the multi-purpose catheter, we're making sure that our wire doesn't push that filter. So I think Dr. Kapoor is giving me a good rail. So we're going to take it all the way down distal, and you can see we're almost at the level distal, right, pretty much hubbing here. So what I'm going to do is I'm going to unplug my port, and I'm going to give some dye to see what is it that we have. Can I have a little dye, guys?
So PK, while you're doing this, this is all good strategy. I think what you've got is a full basket, and it's nothing, you did everything correct. It's a good thing you had the basket.
Yes, sir.
I think it's just, we don't have a basket yet that is made specifically made for the lower extremity with this amount of plaque burden. So often what we'll do is we'll put an exchange length 014 wire inside the basket, take an aspiration catheter, suck out what you can, leave that wire behind, and then take the basket out and see what you got. I think.
So Chris, I think you're absolutely right. You can see here the basket is full and it's doing its job, which I think is why the FDA needs to give an indication for filter in these kind of difficult cases.
Yeah.
And I think so at this stage you can see we've injected, you can see that the basket is full and it's preferentially sitting in the anterior tibial, but now I was afraid to capture this because of the extrusion of debris when we capture it. So what I'm going to do is I'm going to turn on the penumbra device here, which we know this is FDA approved for stroke, and I'm just going to try to just suck some of this back on, okay? And I'm just going to use my wire here to guide me into the basket, okay, which is going to help. So I'm just going to guide into the basket the wire at this stage. There you go. And just kind of without being on the EmboShield wire, which would have then collapsed the filter, I'm able to aspirate this, which is what I'm trying to do here. So now I've made 4 or 5 passes. The flow is good, guys?
Yes. Good.
So the flow is still good, which tells us that we're not going to turn it off. Now give me a little bit more dye. And I'm just going to take a picture. So I think this case illustrated that very nicely. And I think you're right, Chris. I think we could have, it was a full basket, but I'm just worried about how to control the spillover if any occurs.
No, I like your approach, and I didn't realize you could use a penumbra device with a multi-purpose catheter. That's actually very clever.
Mm-hmm. So this is what we did. We did it with a multi-purpose, and I think now the filter is definitely free, and I think there is a little slow flow, but I don't think there's any obstruction distal. So now what I'm going to do is I'm going to capture it. I'm going to walk the device out, and I'm going to load it on my EmboShield wire, and then I'm going to capture this under suction. So this allows me now to make sure that I do not, spill debris as I go ahead up and through it. So now what I'm going to do is I'm just going to go ahead and load the EmboShield wire and go on it. I know that mid-stent is going to give me trouble because of that curvature in the SFA. So I'm going to be a little careful because I still know I have some debris in the stent. So we're going in.
So PK, we've done a study on this with the deep emboli. If 20% of the time, just using the balloon after atherectomy, you get macro debris in the filter. It's a pretty common phenomenon. We rarely have to aspirate the baskets ourselves. Mm-hmm. We tend to pull it all the way, into its retrieval and take it from the sheath. We use a destination sheath with a removal hemostatic valve because many times those debris are large enough you can't even take them through the valve of the hemostatic portion of the sheath. And essentially, you clean up your sheath and the flow will go right back to normal.
So PK, what catheter are you taking down here?
This is a multi-purpose catheter that's going down a 6 French coronary multi-purpose guide.
Okay. And then you're going to aspirate as you pull this back. Now, with the penumbras, if you aspirate and you're not in clot, you can get a lot of blood in your canister pretty quickly. Are you just going to pull it back pretty quickly?
Very slowly, because I still could extrude, and I'm watching the flow in the penumbra catheter now. So I'm just going to pull it right back in and just get it right in. And then at this stage, once it's captured, I'm not, pretty much like you did in the carotids and taught us, don't do a full capture. The advantage of the EmboShield now is allowing me to go ahead, push my wire down safely, so I do have distal access, which I hope I can do. There you go. So now I've got my distal access. Now I'm going to be under suction, and I'm just going to have Dr. Kapoor walk this out. And as you can see, it's being pulled into the guide by the suction, allowing it not to embolize. And I'm praying that we did the right thing here. But again, there's always a chance, even though as care that you take, this can still embolize. So we want to make sure, like you said, it doesn't get caught in the diaphragm, and this is where it's easy for us to just keep it inside the filter here and just pull it out. And guess what, Chris? It got caught in the diaphragm.
That's right, but this is still a very elegant technique, to do everything you can to prevent embolization. I've not seen this before, and I like it.
Oh, no.
That's pretty cool technique,
cool.
actually. Yeah.
All right, cool. So if we were able to pull it back. Sorry about that. So we're able to pull it back. So now we're going to take a picture.
Non-DSA?
A DSA.
Okay, DSA.
Let's go low mag here. In that technique, the wire, we lost wire, but I don't think it should be an issue wiring it. Ready?
So, PK, did you flush your sheath back, like opened up the hemostatic valve and let it bleed back?
You read our mind. As you can see, we're just about doing that.
That happens so frequently, a lot of debris just get captured right there in that valve.
See, now I'm thinking, I should have done the silver. Ready? So again, the nice thing is I'm looking for my pressure. I've got a good pressure. So now I'm going to go ahead and do a nice DSA and just, just make sure that, God willing, everything will look good now. And there's our flow. And there's our flow. Fantastic.
Beautiful example.
So, I think we got lucky in this one, and I'm sorry to bring you back on your lectures, but I thought it was a very important point to show. And I think that we did the right thing in terms of doing the jet stream atherectomy followed by the DCB, although I believe Zilver is an incredibly effective therapy in ISR, as Dr. Zeller showed. So, thanks again. We'll see you soon.
That's good stuff.
Thanks, PK.